बिंदु जी
कुंडी
Now I think I am visible now.
Yes, sir.
Okay. Thanks God. Technology always gives trouble. Am I audible, Dr. Deepa?
Yes, sir. We are ready to start. We can.
Okay. So I think we can start already 4 minutes past 5:30.
Yes, sir.
So should I start?
Yes, sir. We can start.
So, sir, already 485 logins are there, sir.
Right. So once again, welcome back. And let me just share my screen. So can you see my screen, Dr. Deepa?
Yes, sir.
All right. Okay, so I will start from where I left yesterday, and we were on this slide. I mean, so I said that to define or to explain the shape of mammalian cell survival curves, a lot of models have been put forward. But as a radiation oncologist, we only need to understand about these two models, which are very popular model. One is multi-target model. Multi-target model is basically required to understand for the examination purpose, though it does not have any clinical significance, but many times it is asked in your final examination. So you need, and we need to understand the multi-target model. The linear quadratic model is the model which we practice in our day-to-day clinic. So it is very, very important to understand linear quadratic model, and you will really surprise when you will now move through my presentation in next today and in next 2 days, that suddenly you will realize that whatever you practice in your day-to-day clinic is based on some principle or other principle of linear quadratic model, which you have never realized. But after attending this course, you will realize that how interesting it is, that what you have practiced, you have never thought that on what principle it is based on. But after this, definitely you will have a different kind of perspective towards this specialty. So linear quadratic model is very, very important for all radiation oncologists to understand. So let me just go to first multi-target model. Now, according to this model, there are multiple targets inside the cell which need to be deactivated in order to bring death to the cells. It is, it is postulated that a number of targets are more than one, and it is denoted by a letter N, and N can be anything more than one. It can be 2, or it can be 20, or it can be 100. So in order to bring cell death by radiation, all the targets should be deactivated. If N-1 targets are hit, then cell will survive. So N-1 target hits, it results into sublethal damage, and that sublethal damage can be repaired. Now there are two types of cell killing taking place simultaneously to deactivate N targets, which ultimately results into cell death. So what are those two types of cell killing? One is cell kill by single hit event, other is cell kill by multiple hit event. So in single hit event, by a single hit or by single radiation events, all the N targets are hit. And in multiple hit events, we need multiple hit to deactivate N number of targets. And this single hit event is mainly seen in low dose region, and multiple hit events are mainly seen in high dose region. So in low dose region, as I said, two processes taking place simultaneously. So what happens in low dose region? That single hit event result into deactivation of N target, which lead to lethal damage, and finally it results into cell death. While in low dose region, multiple hit event result into deactivation of N-1 target, result into sublethal damage, and this sublethal damage gets repaired and it does not lead to cell death, which means that in low dose region, contribution in cell kill is by only single hit event, and there is no contribution in cell kill by multiple hit event in low dose region. As the dose increases, the contribution by multiple hit event also started. And in a very high dose region, the main contribution in cell kill is by multiple hit event, and relative contribution by single hit event is very small. So this is the basic of multi-target model. So in multi-target model, if you look at the cell survival curve, in low dose region, the reduction in survival fraction is mainly due to cell kill by single hit event. In high dose region, reduction in survival fraction is mainly by death or cell kill by multiple hit event, and contribution by single hit event in this region is relatively very small. Now the question is that what happens between these two dose region? Means that initially when you start in the low dose region, it is mainly the single hit event. After at certain point, after this dose, when you further increase the dose, the multiple hit event also start contributing in overall cell kill. As you further increase the dose, more and more contribution by multiple hit event comes in overall cell kill, and as a result, there is continuous bending of cell survival curve. So in multiple hit event, when the dose increases, it also contribute, and as the dose increases, the contribution by multiple hit event keeps increasing as reflected by size of this latter. I hope you understood now. So we can say that initially all the cell kill is by single hit event. As dose increases, the contribution in cell kill by multiple hit event also appear and increases with increasing dose. Now this leads to continuous increase in survival fraction with increasing dose. This is what I discussed, that in initial portion, when you increase the dose, there is continuous increase in reduction in survival fraction or continuous increase in cell kill till it reaches to 10%. Now this happens because initially all the cell kill is by single hit event, but when you increases the dose, the contribution by multiple hit event keeps increasing. Now this reflects that initial portion is not exponential, and this is a characteristic feature of mammalian cell survival curve. Now, if I will discuss in this slide the reduction in survival fraction by two process of cell kill separately. So you see, this is the low dose region, this is the high dose region. Now this cell survival curve reflects the cell kill by multiple hit event. Let us call it curve A. Now if you concentrate in low dose region, is there any reduction in survival fraction because of multiple hit event? Answer is no, there is no gap. When you increase the dose, yes, now there is contribution by multiple hit event. When you further increase the dose, the contribution increases now. So this will continue as you keep on increasing, the contribution by multiple hit event keeps increasing. Now another cell kill result this type of cell survival curve. So this is the reduction in survival fraction because of single hit event. So now again, just concentrate in low dose region and you see the reduction in survival fraction is there or not because of single hit event? Answer is yes, there is a gap. So this reduction in cell survival curve in low dose region is mainly by single hit event, and we have seen that there is no contribution by multiple hit event. At very high dose, there is contribution by both the cell kill, but see here that contribution or reduction in survival fraction by multiple hit event is from this point to this point, while for single hit event from this point to this point. So in high dose region, main contribution in cell kill is by multiple hit event. So we can say from this graph that in low dose region, main contribution in cell kill is by single hit event, In high dose region, main contribution in cell kill is by multiplicity event. And this is the resultant curve which reflect both process of cell kill, that is singulate event as well as multiplicity event. Now there are two terms which you need to understand. These are the quasi threshold dose and extrapolation number. So what are these two things? Just again try to understand. This is a magnified view of initial portion of the cell survival curve. This is the terminal portion. Now again what I'm going to do, I'm going to make increment in the dose region, and you just concentrate on survival fraction. What happens? So at this dose, is there any reduction in survival fraction? Answer is no. At this dose, still there is no reduction in survival fraction. At this dose, still there is no reduction in survival fraction. At this dose, now there is reduction in survival fraction. So what does it suggest? It suggests that probably up to this dose, there is no effect as far as cell kill is concerned, which means it reflects something like there is a threshold for radiation to act. But we know that there is no threshold for radiation to act. Radiation even in a minimal dose will result into some damage. So that is why, but this curve reflects, or this model suggests that it seems that there is some threshold dose, and that is why we call it quasi threshold, and it is denoted as DQ. I hope you now understand quasi threshold. Now extrapolation number is what? If you extrapolate back this terminal portion of the cell survival curve, where it meets on survival fraction, axis, it gives you extrapolation number, which is denoted with N. So N basically is known as extrapolation number. And in fact, this represents the number of target in the cell which are required to be hit to bring cell death. So if you remember, this is a multi-target model, and I have already told that there are more than one number of target. So what is the number of target of that particular cell line? It can be obtained by extrapolating the terminal portion of the cell survival curve on survival fraction. And now you will understand better that why there seems to be no effect or no reduction in survival fraction at this dose. So what happens that when you give this dose, so suppose N is 10, let me tell you that in this particular cell line, let us presume that N is 10, which means that we need to deactivate 10 targets in order to bring death. So what happens at this dose, only few targets, say 2 targets are deactivated, 8 still survived. That is the reason that there will not be any cell death. At this dose, some more targets are deactivated, say 4 targets are deactivated, but still 6 targets are surviving. That is why again there is no reduction in survival fraction. Here more number of targets are deactivated, but still 3 targets is still surviving, and that is why there is no reduction at this dose also. But this dose, now this is such a high dose that now we presume that all the targets are hit and no target is surviving. That is why the survival curve have started dipping down, means survival reduction or the survival fraction has started reducing. So that ultimately gives you the idea or about the shape of this cell survival curve. So these two terms, I hope now you understand, quasi threshold dose and extrapolation number. So to brief or to summarize the multi-target model, this is a theoretical model. As we know, there is no threshold dose of radiation below which there is no damage. While this model based on quasi-threshold dose, this model cannot be used in clinical practice, and it fails to identify that acute and late reacting tissue behave differently with radiation. So now let us move on to the most or more practical model, that is linear quadratic model. Now this model also suggests that there are two processes of the cell kill, that is linear one and second quadratic. This model says that there is only one target. Multi-target model says that there are multiple targets, but this model says that there is only one target, and that target is DNA molecule. This target or DNA molecule contain two helix, and these two helix are considered as two critical sites which need to be deactivated in order to bring death to the cells. And as I said, there are two processes of cell kill, linear and quadratic. Let us discuss one by one. So this is linear cell kill. So in linear cell kill, it basically represents the probability of two critical sites deactivating on a single radiation event. So what happens in a single radiation event, both the critical sites are deactivated, which result into cell death. And this type of cell death is known as single hit kill or linear cell kill or alpha cell kill. And as you can appreciate, it is mainly seen in low dose region. Now here, the effect of radiation is directly proportional to the dose of radiation. When you remove the sign of proportionality as per norms of mathematics, you have to use a constant. So here we use constant alpha. So effect is equal to alpha D, and survival fraction can be obtained from this formula, that is exponential power minus alpha D. The cell survival curve, because of predominantly this kind of cell kill, is continuously bending, which forms shoulder of the cell survival curve. Another part of the cell killing is quadratic kill. Now this represents the probability of two critical sites getting deactivated by two different radiation events. So what happens then, as a result of one radiation events, only one critical site is deactivated, resulting into sublethal damage. As a result of another radiation events, another critical site is deactivated, resulting into another sublethal damage, and then interaction of these two sublethal damage result into cell death. Now this kind of cell death is known as double hit kill or quadratic cell kill or beta cell kill, and as you can appreciate, this is seen mainly in high dose region, and here the effect is proportional to square of the dose. And when you again take the sign of proportionality, you have to use another constant, and here we use the constant B. So effect is equal to beta D square, and survival fraction can be obtained by this formula. And the portion of the cell survival curve, which basically is represented by beta cell kill, is the terminal portion and a straight line. And remember that double hit kill is similar to multiple hit event of multimodal target theory. So in subsequent hit kill or multiple hit event, it means same thing. So there are two processes of cell kill, the alpha cell kill and the beta cell kill. Alpha cell kill always result into cell death, while beta cell kill either may result into cell death, or if there is a sufficient gap between the two radiation events, then these sublethal damage can be repaired and they again become a viable cell without having any lesion. So the sum of two processes of the cell killing will decide the final survival curve. So final survival fraction will be sum of two processes of cell kill, that is alpha D plus beta D square. Remember, the alpha D is basically represent the intrinsic sensitivity of the cell line, repairable damage. And remember that repair capacity of the tissue, different tissue are different. And this damage will depend upon the repair capacity of the tissue, and different tissue have different repair capacity. As a rule of thumb, I would like again very important message for all of you that late reacting tissue have higher repair capacity, the early reacting tissue have low repair capacity. So kindly remember this very important message. I again repeat, late tissue have higher repair capacity, the early reacting tissue have low repair capacity. Another question is, what is alpha beta ratio, which we use daily in our day-to-day practice? Again, try to understand, focus on the screen. This is the typical shape of the cell survival curve. If you draw a tangent through the initial curvy portion of the cell survival curve, then it will divide the graph into two portions. The upper portion will represent the cell kill because of alpha or because of linear hit. The lower portion will represent the cell kill because of. Now, what I'm going to do, I will move from low dose region to high dose region, and we will see how these two processes of cell kill contribute when we move from low dose region to high dose region. So just concentrate here. Now, let us start from the low dose region. Now, the contribution in cell kill is by only alpha, no contribution by beta. We further increase the dose, is still only contribution by alpha. Further increase is still only contribution by alpha. Now at this dose, you see the red arrow also start appearing, which means that at this dose, the beta cell is also contributing into overall cell kill. When you further increase the dose, the contribution by beta keeps increasing. And at this dose, what are you observing? At this dose, the height of two arrows are exactly similar, which means that at this dose, the contribution by alpha kill is equal to contribution by beta kill. So we can say that contribution by linear kill is equal to contribution by quadratic kill. Linear kill is alpha d, will be equal to beta d square. Now bring beta on the left hand side of equation, d on the right hand side of equation. So alpha beta ratio is d. So alpha beta ratio is basically nothing but the dose at which two processes of cell kill become equal. So alpha beta ratio, I hope all of you must understand that alpha beta ratio is nothing but dose at which two processes of cell kill become equal. Now what happened after this? When you further increase the doses, you see there is exponential increase in contribution of cell kill by quadratic hit. So after this dose, it is mainly the quadratic hit which contribute in cell kill, and relative contribution by alpha is very less. So we can say that in low dose region, it is primarily alpha kill. In high dose region, it is primarily beta kill. Now this can also be defined, this dose can also be defined, or this point also represent the dose beyond which the double hit kill becomes main mode of the cell kill. And before that, cell kill is mainly by single hit or mainly by alpha. So what is alpha beta basically? A dose at which the contribution in cell kill by both processes become equal. Alpha beta also represents the point beyond which the curve becomes a straight line and predominantly double hit event takes place. Now, based on alpha beta ratio, normal body tissue have been categorized into two categories, that is late reacting tissue and early reacting tissue. Now, both the tissue will have, or both type of tissue will have different shape of the cell survival curve because they have different alpha beta ratio. So let us first focus on the left panel, which reflect the late reacting tissue. The shape will be something like this. And if you draw a tangent through the initial curvy portion and try to find out the dose at which two processes of cell kill become equal, you will appreciate that this dose is achieved at a very low dose level. So we can say here that shoulder is more curvy or broad or large, or they have large repair capacity. So the alpha beta ratio has been estimated for most of the late reacting tissue, though it varies slightly between the tissue, but it ranges from 1 gray to 7 gray, and we take an average of 3 gray. Now, right panel shows early reacting tissue. The shape of the cell survival curve is something like this. And again, draw a tangent and try to find out the dose at which two processes of cell kill become equal. Here you will realize that it is achieved at a higher dose, and that is the reason that early reacting tissue have higher alpha beta ratio. So we can say the shoulder is less curvy or small shoulder, or early reacting tissue have low repair capacity. Again, it has been estimated alpha beta ratio for all early reacting tissue. It varies slightly. It ranges from 6 gray to 15 gray, but we take an average of 10 gray. We can also say that in late reacting tissue, the beta cell kill surpass the alpha cell kill quicker and at a lower dose as compared to the early reacting tissue, because we know that this is the point beyond which the beta cell gets predominant process of cell kill, and it is achieved earlier as compared to early reacting tissue. I hope I am clear to all of you. Now, as I said that alpha beta ratio has been estimated for all the normal tissue. For early reacting tissue, it ranges. The different tissue have different alpha beta ratio, but we take an average of 10. Similarly, late reacting tissue have different alpha beta ratio for different late reacting tissue, but again we take an average of 3. We have also estimated alpha beta ratio of most of the malignant tumors. Malignant tumors behaves like an early reacting tissue. They have high alpha beta ratio, though it varies from one tissue, one cancer to another cancer. But we take an average of 10, except 2 cancer, prostate and breast. And they behave, prostate and breast behave like a late reacting tissue. They have low alpha beta ratio. And that is the reason that we have now changed our practice, the way we use fractionation scheme for prostate cancer and for breast cancer, which I will discuss in my subsequent modules. So alpha beta contribution, if you see for early reacting tissue or tumor, because tumor and early reacting tissue have similar alpha beta ratio. So this at 10 gray, the contribution by alpha is equal to contribution by beta. In clinical practice, we are using 2 gray per fraction. So if you look at the 2 gray point, then you will appreciate that at 2 gray, main contribution in cell kill is by alpha and very small contribution in cell kill by beta. Now, putting these two curves, the early reacting tissue and late reacting tissue together, so that you can have a better idea and compare better. Now, this is the initial portion or the shoulder of early reacting tissue or tumor, because both have the same alpha beta ratio. So this basically is less curvy or small shoulder, or it has got less repair capacity. Now this is the initial portion of late reacting tissue. Now this is more curvy, or we can say it has got a broad shoulder, or it has got a large repair capacity. And this is the terminal portion, which is a straight line for both type of tissue, whether it is late reacting tissue or whether it is tumor. So now I'm sure that now you can differentiate between the two, the early reacting tissue or the tumor versus late reacting tissue cell survival curve. So that finishes my second module, and I think, I think the linear quadratic model should be very clear to all of you. And I will stop at this point and will take some question. If you have any question regarding the cell survival curve, I'm happy to answer. So Deepa, if there is any question, I will be happy to answer.
There is a request if you can explain the early reacting and late reacting tissue once more.
Okay, right. Sure. Okay, right. So, based on alpha beta ratio, the normal tissue have been categorized into 2 categories. All of you know, they are late reacting tissue and the early reacting tissue, because they have different alpha beta ratio. And naturally, if they have different alpha beta ratio, which means that the shape of the cell survival curve will be different. So let us study the cell survival curve first for the late reacting tissue. Now, late reacting tissue, the shape is something like this. And you can see the initial portion or the shoulder is more curvy. And if you try to find out the dose at which 2 process of cell kill becomes equal, because alpha beta ratio is the dose at which 2 process of the cell kill becomes equal. So again, you need to draw a tangent and find out the dose at which 2 process of the cell kill become equal. And you appreciate that this is achieved at a lower dose here, right? because you can see the height of the two arrows are exactly similar. So this is the dose at which two processes of the cell kill become equal, and it is achieved at a lower dose. And that is the reason that alpha beta ratio for late reacting tissue are low. And we can say that shoulder is more curvy, right? Or broad or large, right? So shoulder is more curvy, broad or large shoulder, or as I said that late reacting tissue have large repair capacity, right? And as I said that alpha beta ratio ranges for late reacting tissue from 1 gray to 7 gray, and we take an average of 3 gray. Now on the right panel, shape of the cell survival curve is something like this, which belongs to early reacting tissue. Now alpha beta ratio of early reacting tissue are similar to alpha beta ratio of of tumor. So tumor will also have the similar kind of shape of the cell survival curve. So again, you find out the dose at which two processes of cell kill become equal. For this, what you have to do, draw a tangent and find out the dose where the height of two arrows are exactly similar. And now you appreciate that in early reacting tissue or tumor, it is achieved at a higher dose if you compare with the late reacting tissue. And that is the reason that alpha beta ratio for early reacting tissue are higher than alpha beta ratio of late reacting tissue. And here we call it that shoulder is less curvy or shoulder is small, and they have low repair capacity. So early reacting tissue have low repair capacity. So this alpha beta ratio ranges from 6 gray to 15 gray depending upon the type of the tissue. We take an average of 10 gray, right? Now this is the point beyond which predominant process of the cell kill will be beta. So we can also say that in late reacting tissue, beta cell kill surpass the alpha cell kill at a lower dose as compared to early reacting tissue, right? I hope I am clear now, Deepa.
Yes, sir.
Yeah. So any other question related to cell survival curve?
In fact, there are many questions.
So I can take a few questions, I mean, which are relevant and important. You can select and, you can.
There is a question like if you can repeat what is extrapolation number.
Okay. Right. Okay. So quasi threshold, I hope all of them understood, right? So
There was actually a question on quasi threshold also.
Yeah, what is that?
Can you repeat quasi threshold is what they have asked?
Okay. So just you need to concentrate on the screen, right? Only then you will be able to understand. It's very simple. See, now these two terms have been put forward by this model to explain this kind of shape of the cell survival curve, right? So these are basically the hypothetical terms, right? They don't have any value or any place in our clinical practice. First thing is this. So I will say that multi-target model is more like a theoretical model, while linear quadratic model is more like a practical model, right? So this is just, everything is hypothetical. So just try to understand. Now, what I'm going to do, I'm going to give increment in the dose region, and you see what happens to survival fraction. Actually, that is the disadvantage of the virtual class or virtual webinar, that I cannot ask student what you are observing, right? So I have to tell myself only. Anyway, so just concentrate on the state. Now I give this dose and there is no reduction in survival fraction, which means there is no cell kill, right? When I further increase the dose, still there is no reduction in survival fraction, which means still there is no cell kill. When I further increase the dose, still there is no reduction in survival fraction, which means still there is no cell kill. When I further increase the dose, and now you see there is reduction in survival fraction, which means that up to this dose, there is no effect of radiation on the cell kill. So it gives you an impression that like there is a threshold dose for radiation to act, means that radiation will only act beyond that threshold dose. But we all know that there is no threshold for radiation to act. Even the small dose of radiation will result some kind of damage. So that is why, though this model suggests that there is a threshold dose, but we know there is no threshold dose in reality. So that is why we call it quasi threshold. Means it looks like a threshold, but it is not. It is just a hypothetical terms. In actual or in reality, no such thing happens. I'm sorry. So I hope now you understand the quasi threshold. Now extrapolation number is that you extrapolate back this terminal portion, and where it meets on the survival fraction, that gives the extrapolation number. And this extrapolation number is nothing, but this is the number of target in a cell which need to be deactivated in order to bring death to the cell, because this is a multi-target model, and multi-target model says that there are more than one target which need to be deactivated. So this will give you the number of target in that particular cell line for which you have generated the cell survival curve. Suppose in this example, the value is 10, which means that there are 10 targets in this cell line in order to bring death to the cell. Now, to make you make this point more clear that why it seems that there is no cell death here. Again, hypothetical, remember. Now, when you give this dose, now this dose is only sufficient to deactivate 2 targets. 8 target is still surviving. So naturally there will not be any death. When you further increase the dose, it will deactivate more number of target, but still 6 targets not deactivated. When you further increase the dose, it will further increase the number of target which will be deactivated. But not all the 10, still 3 targets are surviving. So that is why up to this point, there is no reduction in survival fraction. At this point now, this is the dose which is sufficiently high to deactivate all the 10 targets. And that is the reason that after this, you will start seeing dipping in survival fraction or reduction in survival fraction. I hope I am clear now.
Yes, sir.
Okay, so I think I should move on to the next module so that, you know, I can finish well in time. So up to these, you know, 2 modules, I just discussed the theory part of the cell survival curve. And I presume now that all of you have a good understanding of linear quadratic model, right? I want all of you to have a good understanding of linear quadratic model, because now from this module onward, I will discuss the clinical application of LQ model.
Can I interrupt you once, sir? There is a repeat question from like, what is the relation between the curviness and repair capacity? Curviness.
What is the, can you repeat?
Relation, why curviness is related with repair capacity, or?
Why? I didn't get.
The curviness of the cell survival curve. The relation between the repair capacity and the curviness of the cell survival curve.
So basically the, you know, this is the shape of the cell survival curve, and when they, you know, estimated the repair capacity, it was found that repair capacity is higher in late reacting tissue as compared to tumor or early reacting tissue, right? And the shape, you know, they get on the, while generating the cell survival curve in laboratory or on animal models.
Yes, sir, that is clear.
So let me go to the clinical application now. And this is again very interesting. I would ask all of you to be attentive. I mean, this is interesting because this is something which all of you are doing on your day-to-day clinics. And you will now be very happy to see that whatever you practice, how nicely it is related with linear quadratic model. So that makes this module very, very interesting. And let me start from the normal tissue injuries to radiation, right? The normal tissue, have two patterns inside the body. One is hierarchical pattern, the other is flexible pattern. In hierarchical pattern, proliferative capability, but this is not a functional cell. It multiplies, divide, and gives rise to progenitor cell. Now, this progenitor cell has a high proliferative capability, but again, it is non-functional. Now, this progenitor cell divide and gives rise to functional cell, which is a differentiated cell. It has no proliferative capability, but it is a functional cell. And these type of tissue, they respond rapidly to radiation, and they are responsible for early radiation reaction. In flexible pattern, we have stem cells which have got low proliferative capabilities, but it is a non-functional cell. It divides and gives rise to progenitor cells, or this is also called functional cell. So primarily it is a functional cell, but it also retains some proliferative capability. And in case of need or in case of demand, these functional cells can also multiply. And this type of tissues, they respond slowly to radiation, and they are responsible for late radiation reaction. Now, these are the various factors on which normal tissue injury depends, or normal tissue injury will be affected by these various parameters. I will discuss one by one. So first, let us discuss the fraction size, how it affects the two types of tissue, that is early reacting tissue and the late reacting tissue. Now, we know that shape of the cell survival curve of two types of the tissues are different. The upper panel belong to late reacting tissue. The lower panel belong to early reacting tissue. Both have different alpha beta ratio. Now, look at the D1. If suppose you give D1 dose, it reduces the survival fraction for both type of tissue, late reacting tissue and early reacting tissue. Now, when you increase the dose from D1 to D2, it further reduces the survival fraction in both type of tissue, but you will appreciate that reduction in survival fraction for late reacting tissue is much more as compared to early reacting tissue. So what does it suggest? It suggests that when you increase the dose per fraction, remember, it damages late reacting tissue more than early reacting tissue, or vice versa, which means when you reduce the dose per fraction, it will reduce the late toxicity, which means that it will causes less damage to late reacting tissue. And this has a clinical implication or clinical application. How? Now, if I ask you how you treat head and neck cancer by non-IMRT plan, the answer is shrinking field technique. All of you must be practicing shrinking field technique. So in shrinking field technique, what you do basically, first you treat whole neck, including primary, and you deliver a dose of 46 gray, 23 fraction, 2 gray per fraction. Now, after 46 gray, you will reduce the posterior portion of the radiation field so that spinal cords are out of the radiation portals. Why? Because this is the tolerance dose of spinal cord. So if you calculate the biological effective dose of spinal cord, it will be around 77 with this physical dose and fractionation scheme. Now, nowadays, most of you are treating head and neck cancer with IMRT. Now, in IMRT, you generate a single plan. For example, you deliver 70 gray in 35 fractions. So you generate a single plan and put a constraint of 46 gray to spinal cord. But when you generate a single plan, remember that now you have to deliver this 46 gray in 35 fraction, which means that dose per fraction is reduced from 2 gray per fraction, that is 1.31 gray per fraction. And what we have seen in previous slide, that when you reduce the dose per fraction, it will spare the late reacting tissue. So in non-IMRT plan, or you are putting a tolerance, physical tolerance to the spinal cord, as well as biological tolerance to the spinal cord, which is 77 gray. In IMRT plan, you are putting 46 gray means tolerance, physical tolerance to the spinal cord. But if you calculate the biological effective dose, it is much less than biological tolerance of the spinal cord, which means that still there is a scope for giving more dose of radiation to the spinal cord with this fractionation scheme, right? So what I'm trying to tell, I'm not trying to tell that you give more dose to the spinal cord. The clinical implication of this knowledge is, you will realize when I will discuss the re-radiation in head and neck cancer. So remember that IMRT is always better than non-IMRT in head and neck cancer, because it will deliver less than tolerance dose to the spinal cord if you put a constraint of 46 Curie, and it will help you during re-radiation, which I will discuss in a short while. Second factor on which the normal tissue injury will depend, it is the turnover or proliferative status. Now, what is proliferative status or the turnover? It basically determines the timing of manifestation of radiation injury, and this is also known as latency, which means the time period between the exposure and manifestation of the effect. Because we know that if any organ is exposed today, immediately it does not lead to clinical manifestation. It will take some days for clinical manifestation to occur. We know that different tissue have different latent period before the radiation injury is manifested, and it will depend upon the turnover or proliferative status of that particular tissue. So what is that exactly? Now try to understand. I have taken the example of jejunum villi. Just concentrate on your screen again. We know at the base of villi there are crypts which contains stem cells. Now these stem cells are non-functional cell. They divide and gives rise to progenitor cells. Now progenitor cells are also non-functional cell. They further divide and gives rise to differentiated cells, which are now functional cells. Now these functional cells will move to the villi, perform its function, will die and shed into the lumen. And this process will continue. An important point here is that lifespan of this functional cell is 2 weeks or 14 days. So once it is produced, then total lifespan of this functional cell is 14 days. Now what happens? If you irradiate jejunum villi with radiation, what will happen? That it will depopulate the progenitor cell. So now there is no source of differentiated cell. You don't have any source because it has been killed, or progenitor cells have been killed by radiation. But clinical manifestation in the form of diarrhea will not appear immediately, because we know that already produced functional cells which were produced before irradiation, they are at different stage of migration to villi. So what will happen? That when this cell will live its life and will die, then cell in the next queue or the next cell will take its position and perform the function. When this cell will die, this cell will take its place. When this cell will die, this cell will take its place, as unless all the cells are consumed, right? And we know, so unless all the cells are consumed, there will not be any manifestation of radiation injury. And we know that total lifespan of differentiated cell is 14 days. So up to 14 days, there will not be any radiation symptoms. Once all the cells which were produced before the irradiation are consumed by villi, now the clinical manifestation will appear in the form of diarrhea. So we can say that latency is 14 days in case of jejunum. Now this is the actual experiment on normal villi of murine. So you can see this is the normal villi. Crypts are present. When you deliver 10 gray, what you observe after 24 hours, there is depopulation at crypts, but there is no change in villi. Why? Because already produced functional cells supplying to villi, right? Even after 48 hours, you will see there is no change in villi because still there are some cells left which are performing the function of villi. You can see some regenerative activity started here after 72 hours. Now you see there is shortening of villi. Now the clinical symptom will occur because all the cells now have been consumed. You can also observe regenerative activity at the crypts. Now, after 4 days, you can see regenerated crypts. They have again started producing progenitor cells, which again start producing, you know, the functional cell to villi, and you can see that there is early recovery in villi. And after 5 days, you can see very good recovery in villi. So this is what happens in human being also. So this was the example on animal, which finish in fifth day, but usually in human being, it takes 14 days or more than 14 days. Now, with this knowledge, let me give you one important message that there is no relationship between latency and tolerance. So what does it mean? Again, try to understand. Now, tolerance basically represents the organ sensitivity to radiation, while latency, as I just discussed, is the time interval between exposure and manifestation of radiation. To make my point more clear, I am showing you normal tissue complication probability curve of two organs, that is bone marrow and the gut. Now, Ntcp I will discuss in my subsequent module. Here at this point, you just remember that more the curve on the left-hand side, more sensitive it is to the radiation. So if I ask you out of these two organs, which is more sensitive, naturally it is the bone marrow. And we can see from here that if you deliver or if you expose 70 gray of radiation, then for gut, the complication rate will be less than 5%. But for bone marrow, it will be more than 50%. So this reflects clearly that bone marrow is more sensitive to radiation than gut. But if you look at the latency, it is higher in bone marrow as compared to gut. It is 30 days, while in gut it is 14 days, which means that the clinical manifestation of bone marrow irradiation will appear after 30 days, while for gut, it will appear much earlier. So if you do a whole body exposure, diarrhea will appear early, then pancytopenia, and don't be under this expression that if diarrhea appears early, it means that gut is more sensitive to radiation than bone marrow. This is what I'm trying to tell you, that if manifestation or clinical symptom of any organs appear early, it does not mean that that organ is more sensitive to radiation. Similarly, take an example of testis. We know that in testis, we have a stem cell which multiplies and gives rise to sperm, and it takes 60 days from a cell to form a sperm. So if testis is exposed to radiation, it will kill the stem cell, but you will not observe azoospermia up to 6 to 8 weeks time, because already produced cell will continuously keep on supplying sperm. So only azoospermia will be observed after 6 to 8 weeks. But if you look at the tolerance of the testis, it is very, very sensitive, just 6 to 8 gray for permanent sterility in 2 gray per fraction. But if you compare with gut, symptoms start much, much earlier. You compare much, much earlier, but tolerance is very, very high as compared to testis, 50 gray or 45 gray in 2 gray per fraction. So the message should be very loud and clear to all of you that if clinical manifestation of radiation injury appears early, it does not mean that the organ is more sensitive and has less tolerance dose. No, it is just a question of its turnover or proliferative status. I hope I am clear now. Clinical relevance of turnover, radiation-induced acute injury does not start immediately following radiation. I think every day we observe this thing. In head and neck cancer irradiation, mucositis usually appear after second week or during third week. We all, every day we see that. Diarrhea similarly start 2 to 3 weeks after pelvic irradiation. Every day we see these things. So that was about the overall turnover time. Now, third factor on which normal tissue injury depends, that is overall treatment time. This is again very important. And I again would like all of you to concentrate on your computer screen. Now, most of the, most of the normal cells remain in steady state. What does it mean? It means that number of cells produced at any given point of time is just equal to number of cells being died. So we can say that cell loss factor is 1, which means that tissue will not grow. But as a result of some injury, whether radiation injury or physical injury, this tissue will go into regenerative phase. In regenerative phase, the number of cells produced are more than number of cells dying at any point of time. Or we can say that cell loss factor is less than 1, and here the tissue will grow. So overall treatment time basically affects the normal injury because of repopulation or regenerative activity. So this is basically, I am referring to accelerated repopulation, right? Now, how it affects in our, how it basically have an impact in our clinical practice. Now, again, this graph is very important to understand. Now, this is the graph showing the relationship between isoeffective dose versus overall treatment time for early reaction as well as for late reaction. For early reaction, I have taken mucositis for say grade 2 mucositis. For late reacting tissue, I have taken myelopathy, say grade 2 myelopathy. These experiments are, being done on rat. Now try to understand. First, let us look at early reacting tissue. Suppose you deliver the radiation in 4 days. Then for grade 2 mucositis, you will require roughly 20 gray. If you prolong your treatment from 4 days to 10 days time, then for the grade 2 mucositis, you have to deliver 25 gray, which means that if you deliver 20 gray in 10 days time, then there will not be grade 2 mucositis, because for 10 days to have a grade 2 mucositis, you have to deliver 25 gray, while you are delivering 20 gray in 10 days. So there will not be any mucositis. But if you deliver 20 gray in 4 days, definitely there will be some grade 2 mucositis. So we can say that increasing overall treatment time is spare the early reacting tissue. Now coming on to the late reacting tissue, just now concentrate on this graph. Whether you finish your radiation in 4 days time or 10 days time, there is no change in total dose, which will result into grade 2 myelopathy. So there is no change in the dose, whether you deliver in 4 days time or 10 days time. So we can say that increasing overall treatment time will not spare the late reacting tissue. While increasing the overall treatment time, it will spare the early reacting tissue. So these two messages are very important, and we can say that during radiation treatment, the accelerated repopulation or regeneration only seen in early reacting tissue and not in late reacting tissue. Clinical relevance, we all know that if we protract the overall treatment time beyond the conventional 6 weeks time, it may result in sparing of the acute reaction. But remember that tumor may also be spared. I will discuss this thing in detail in my subsequent modules. Decreasing overall treatment time to less than conventional 6 weeks time may result in more acute normal tissue reaction. We have enough, clinical data on this statement. Third, treatment time do not have any effect on late reaction. This is again very important, that treatment time have an effect on early reacting tissue, but no effect on late reacting tissue. As I said, that when you reduce the overall treatment time to from 6 weeks, you will encounter more acute normal tissue reaction. As I said, that there are plenty of data available in the literature. I will just discuss this one single trial. Nowadays, we are trying to reduce the overall treatment time for prostate cancer from conventional 8 weeks time to less than 8 weeks time. And this is a Hyperthermia trial where the conventional radiotherapy fractionation was compared with hypofractionated radiotherapy. And this group specifically looked at acute reaction. So what they observed that acute GI toxicity was seen higher in patient treated with hypofractionated arm. And the reason is, now you can say, because you have reduced the overall treatment time from 8 weeks to 6.5 weeks. So there were less regenerative activity, and that is the reason you get higher GI toxicity. Of course, another reason is that you have increased the dose per fraction from 2 gray to 3.4 gray, which is more cell kill, which will result into more cell kill. Again, coming back onto the same graph. Now, if you just concentrate on late reacting tissue, that is myelopathy. Now, after a long gap, you can see that this curve also start elevating similar to the early reacting tissue, which means that some regenerative activity or accelerated repopulation is also seen in late reacting tissue, but after a long gap. Like in this experiment, almost after 100 days, there is regenerative activity and in the spinal cord, and this helps us understanding the re-radiation, especially in head and neck region. So let us first look at the regenerative activity in spinal cord. Now, spinal cord has got one bad thing, one good thing. The bad thing is that spinal cord remember the irradiated dose. Good thing is that with time, the spinal cord start forgetting the irradiated dose. So the dose of radiation which can be delivered safely to the spinal cord during re-radiation will depend upon two factors. One, how much dose is remembered at the time of re-radiation by the spinal cord, and this in turn will depend upon the priming dose to the spinal cord, which means that how much dose you have delivered to the spinal cord during first irradiation, right? And second parameter on which the spinal cord dose during re-radiation will depend is time of re-radiation. And I will discuss, one by one. So first, let us look at remembered dose to the spinal cord. Now, this graph is showing the relationship between the remembered dose versus the priming dose. Priming dose means that dose which we have delivered during first irradiation. Now, if you have delivered 100% of the tolerance dose to the spinal cord during first irradiation, means 45 gray, then it will not forget anything. It will remember full dose, and re-radiation probably will not be possible, right? But if you deliver during first irradiation 70% of the 45 gray, that means 70% of the tolerance dose, then it will just remember 20% of the tolerance dose, which means that still you can deliver 80% of the tolerance dose to the spinal cord during second irradiation. Sorry. If you deliver 40% of the tolerance dose during first irradiation, then it will remember nothing. Close to 100% it will forget, which means that close to 100% of tolerance dose you can deliver to the spinal cord now. But remember that these data are on animal experiment. We cannot just apply to the human being same figure, but certainly it is giving a very important message that in human being also there is repair of the spinal cord, and this repair will depend upon the priming dose to the spinal cord. Second factor is that as the time interval between first irradiation and second irradiation increases, the dose which can be delivered to the spinal cord safely keeps increasing. So if 100 days, you can deliver 20% of the tolerance dose. If 200 days, you can deliver 40% of the tolerance dose. This is again an animal experiment which suggests that as the time interval increases, the percentage recovery in spinal cord keeps increasing. So with this background now, I show you the two IMRT plan of the same patient of head and neck cancer. In one plan, you have put a spinal cord constraint of 45 gray. On another plan, you put a constraint of 31 gray, and you see both plan, there is no compromise in target coverage. And if I ask you which plan is better, now with this knowledge, with this understanding, all of you should say that this plan is better. Why? Because in this plan, you have delivered 100% tolerance dose to the spinal cord. So in case of relapse, you will not be able to re-radiate this patient. But if you treat with this plan, here you have delivered just 70% of the tolerance dose to the spinal cord. And after 2 years, it will just remember 20%. So you can re-radiate with 80% of the tolerance dose in 2 years. But remember, these data are from the animal models. We cannot extrapolate the same figure here. But as I said, but they give a definitive indication that you can re-irradiate spinal cord in this situation, but you cannot re-irradiate spinal cord in this situation. So here is the message, important message now with all these understanding, that when you treat head and neck cancer with IMRT, kindly put a spinal cord constraint less than 45 gray. It may be 44, it may be 43, it may be 42, whatever minimum you can achieve without compromising the target coverage. So whatever you can achieve to the spinal cord, I think that will be helpful in future if that patient comes with relapse and patient need re-radiation. And now you know the reason why I am telling this, right? Ladies and gentlemen, you know that in our country, the commonest malignancy is head and neck cancer. We also know that 2/3 of these patients present in locally advanced disease when treatment of choice is chemoradiotherapy. We also know that out of these patients, almost 60% of the patient will come with the relapse, maybe after 1 year, maybe after 2 years. Now, out of these relapsed patients, only 20 to 30% will be amenable to salvage surgery. Majority of these patients will come to you for re-irradiation. So if you keep this thing in mind, that during first irradiation, always treat with IMRT, first thing. Second, always try to put a constraint less than tolerance dose to the spinal cord. Then you will be more comfortable for re-irradiation. So this is a very, very important message which I want to deliver to you. And you can see that even if you see, if you are not able during first irradiation, you are not able to reduce the constraint from 45 gray. Still you are doing a favor. Why? Because you are delivering, if you are treating with IMRT during first irradiation and you are generating a single plan, then biological effective dose is still much less than biological effective dose, or I can say that biological tolerance with IMRT is still, there is a scope of 11 gray if you treat with IMRT, but if you don't treat with IMRT, then probably you will not be able to re-irradiate. So you can see still you are delivering 14% less PED than the tolerance dose. So I have seen that IMRT is promoted only on the basis of sparing the parotid gland or on the basis of sparing the swallowing structure. But I say, even if you are not able to spare the parotid gland, or even if you are not able to spare the swallowing structure, but still you treat with IMRT so that you can, in case of re-radiation, you can deliver some dose to the spinal cord. You have that much of, the liberty. So that is why I always say that IMRT, always treat head and neck cancer with IMRT. So at this point I have already covered that if you treat first irradiation with conventional radiotherapy, probably you will not be able to re-irradiate. But in IMRT, of course, we will be able to re-irradiate. So that was about the overall treatment time. Now, fourth factor is organization of functional subunit in the organ on which the radiation, injury to the normal tissue depend. So let me discuss the functional subunit of critical organ. We know that functional subunit is an independent subunit of normal tissue, and these functional subunit basically arranged in two patterns, either in the serial pattern like in spinal cord or in parallel pattern like lung. This is something like electric circuit, which all of you might have studied in your +2 physics. We have electric circuit in two patterns, the serial pattern and the parallel pattern. Now in serial pattern, what happens that if there is a single functional subunit damaged, which means that there is a breach, now the current cannot flow, which means that single subunit, if destroyed or damaged, then whole organ will be non-functional. So we can say here in serial structures, volume of the organ is not important, but it is the point dose which is important, and we should always keep less than tolerance dose of that particular organ, like 45 gray to the spinal cord. Parallel organ, even some of the subunits are damaged, current can still flow through alternative route, which means that organ will still be functional. Unless a critical volume is damaged, now the organ will not be functional. So we can say that volume of the organ is important. Same thing again in this slide, in parallel organ, if some subunits are damaged, the organ will be functional. Even some more subunits are damaged, even some more subunits are damaged, the organ will be functional. Unless a critical volume are damaged, then organ will not be functional. So we can say radiative volume of the organ is important, and we can say that low dose to large volume is hazardous, but high dose to a low volume may be safe. And that is the reason, with this understanding, we are now able to treat liver lesions or the lung lesions by SBRT, where we are delivering very high dose of radiation, but to a lower volume. So this understanding enables us to do SBRT of liver and lung. While in serial organ, dose is important, point dose is important, and we can say that high dose to small volume is hazardous, but low dose to large volume may be safe. Now, this is a three-dimensional graph showing relationship between normal tissue complication probability, partial volume, and dose of radiation. This is for the heart. So it is basically showing the effect of volume of irradiation of an organ. Now, looks complicated, but very simple. Just try to understand. Now, if you irradiate 50% volume of the heart, then this is the normal tissue complication probability curve. And this shows that safe dose is around 40 gray. After this, there will be complication, right? If you irradiate 100% volume of the heart, then safe dose will be shifted towards left now, around 30. So if you increase the volume, the safe dose will be less, which you can deliver to the heart. If you irradiate, say, 25% of the volume of the heart, then this safe dose is now shifted towards right. Means now you can deliver 60 gray. So this is just showing the effect of volume on normal tissue complication probability and on safe dose which you can deliver to these organs. And it suggests that as the partial volume decreases, the safe dose which you can deliver to the organ can increase. Now, again, looking at the volume effect of Ntcp. For Ntcp, now some of the organ will behave like this, what I'm going to describe now. Now, what will happen that if you treat, say, 100% of the volume, then safe dose is around, say, 45 or 50 gray. Safe dose means that it will result into less than 5% complication rate. If you irradiate 2/3 volume of that organ, then safe dose is now around 60 gray. If you irradiate 1/3 volume of that organ, the safe dose is now around 80 gray. So the same thing, that as the volume decreases, the safe dose which you can deliver keeps on increasing. And this kind of relationship is mainly seen in parallel organ. So volume effect is mainly seen in parallel organ, and in parallel organ, while you plan the radiation beam, it is useful to have less number of field so that volume of the organ is kept low. Now some organ behaves like this, whether you treat 100% volume or 66% volume or 1/3 volume of the organ, there is no change in the saved dose, remains same. It means that there is no volume effect on these organs. And this kind of relationship is seen in serial organ, right? So that if you plan serial organ, the radiation portals should be as many as possible so that dose is distributed over larger volume, but peak dose never reached. So these were the various factors on which the normal tissue injury depends. And just to summarize, the early tissue are rapidly proliferating tissue. Early reactions are reduced by lengthening overall treatment time, which I have already discussed, keeping the interval between fraction to more than 5-6 hours so that the repair of sublethal damage takes place. Late responding tissue, they are slowly proliferating tissue. The changes in overall treatment time do not have much effect on late responding tissue, I have already discussed. And late reactions are reduced by reducing the dose per fraction, as I already discussed. Now, another important message. When we change fraction size, like if we increases fraction size, then we have to find out the isoeffective dose. Remember, the isoeffective dose is always calculated based on alpha beta ratio of late reacting tissue. Never calculate isoeffective dose based on alpha beta ratio of early reacting tissue or alpha beta ratio of tumor. Because if you calculate isoeffective dose based on alpha beta ratio of tumor or early reacting tissue, then it will damage late reacting tissue more and you will have more late toxicity. Same thing here I am trying to explain. Now this is the cell survival curve for early reacting tissue. This is the cell survival curve for late reacting tissue. If you deliver say D1 dose, it will reduce survival fraction to both type of tissue. When you increase the dose from D1 to D2, it further reduces survival fraction to both type of tissue, but you observe that reduction in survival fraction is much more in late reacting tissue as compared to early reacting tissue. So always calculate isoeffective dose using alpha beta ratio of late reacting tissue, but if you calculate isoeffective dose based on early reacting tissue, then you will overestimate the dose and it will cause more damage to the late reacting tissue. Now coming on to the biological effective dose. Now biological effective dose has been evolved from linear quadratic models. Some mathematics are here, but it is very simple, though I try to avoid mathematics as much as possible, because as a student of biology or as a student of medicine, we don't understand mathematics much. But here, it is necessary to understand some mathematics, but it is very, very simple. All of you will understand. We already now know that overall effect will be sum of two processes of cell kill, that is alpha D plus beta D square. Now D is total dose. It can be written as number of fraction multiplied by dose per fraction, and take it will be alpha D plus. Take D outside the bracket, it will be ND alpha plus beta D. Take alpha also outside the bracket. Am I, Dr. Deepa, am I audible?
Yes, sir, you're audible. We lost you for a few, like in between there was a crack.
Now it is okay?
It's okay now.
So from where I can start? I mean, it was just fraction of second, or should I
Yes,
go?
sir, fraction of second when you were reading out that equation only. Just.
Okay. So here, the sum of the effect will be sum of two processes of cell kill, that is alpha D plus beta D square. D is total dose, so we can write down as number of fraction multiplied by dose per fraction, and you take n outside as a common. So it will be alpha d plus beta d square. Now this small d is dose per fraction. You take this small d outside, it will be n d alpha plus beta d. Take alpha also outside, it will be 1 plus g divided by alpha beta ratio. Now take this alpha on the left hand side of the equation. So E upon alpha is equal to n d multiplied by 1 plus d divided by alpha beta ratio. This E upon alpha is biological effective dose. N is number of fraction, D is dose per fraction. So we can say this is total dose. And this whole expression is relative effectiveness. So biological effective dose is equal to total dose multiplied by relative effectiveness. And relative effectiveness is this whole expression, 1 plus dose per fraction divided by alpha beta ratio. If dose per fraction is same, then relative effectiveness will be inversely proportional to alpha beta ratio, which means that relative effectiveness of this dose will be more for tissue having low alpha beta ratio, which means that late reacting tissue will have more relative effectiveness as compared to early reacting tissue. And that is another reason, and that is why same thing, same message, that when you increase the dose per fraction, it will have more damaging effect on late reacting tissue. So I will just again show you by some mathematics. Suppose dose per fraction is 3 gray. So for late effect, if you calculate the relative effectiveness, then it will be 1 plus dose per fraction is 3, alpha beta ratio for late effect is 3, it comes out to be 2. For early effect, again calculate the relative effectiveness, it is 1 plus dose per fraction is 3 divided by alpha beta ratio, which is 10 for early effect, and it will be 1.3. If you double the dose from 3 gray to 6 gray, again you can calculate the relative effectiveness for late effect, it is now 3. Relative effectiveness for early effect, it is now 1.6. So what are you observing? Now you observe that doubling the dose from 3 gray to 6 gray result in increase in late effect by a magnitude of 1, but for early reacting tissue, it just increased by a magnitude of 0.3 or 1/3. So this again shows that when you increase the dose per fraction, it causes more damage to the late reacting tissue as compared to early reacting tissue. Now, this is the formula which we derived. Suppose total dose is same, number of fraction is same, and dose per fraction is same, then your biological effective dose will be inversely proportional to alpha beta ratio. Now, suppose this is the cell survival curve for some cell line. Now, if you deliver, let us see the contribution at 2 gray. Now at 2 gray, main contribution is by alpha cell kill and very little contribution by beta, right? Now, if by any means, if you increase the steepness of this cell survival curve, which means if you sensitize the cell line, then you will have a steep curve. And now at 2 gray, you see the contribution by beta has increased. And this exactly is done by one process which many of center are using, that is hyperthermia. So what hyperthermia does, apart from other mechanism of action, the one mechanism of action along with radiation is that it inhibits repair of the radiation induced damage, right? Which means that it increases the quadratic component or beta component of alpha beta ratio. Or we can say that it reduces the alpha beta ratio of cell survival curve compared to RT alone. Because if you give RT alone, then this is the cell survival curve and alpha beta ratio will be obtained somewhere here. But with making the curve more steep by hyperthermia, now you can see that alpha beta ratio has been shifted towards left side. So it reduces the alpha beta ratio of cell survival curve. I'm sorry. And this has been, published very recently, just last year, that hyperthermia with radiotherapy reduces the tumor alpha beta ratio. Now let us look at clinical application of biological effective dose. One is to calculate the isoeffective dose. What we mean by isoeffective dose, which means that if we are using two fractionation scheme, then both the fractionation should have the same effect, either in terms of tumor control or in terms of side effect. Now, conventionally, we know we give 60 gray, 30 fraction in 2 gray per fraction. If dose per fraction is increased from 2 to 4 gray, then what will be the isoeffective total dose, right? So isoeffective means that both the fractionation will have same effect, which means that biological effective dose of one fractionation scheme will be equal to biological effective dose of another fractionation scheme. And we know BED, this is the formula of BED. So ultimately, this is the expression which we get. Now remember, we will have to calculate the isoeffective dose for late reacting tissue separately, for early reacting tissue separately, because we now know that by BED ultimately depend upon alpha beta ratio, and alpha beta ratio for these two types of tissue are different. So we need to calculate the biological effective dose or isoeffective dose separately. So let us calculate for late reacting tissue. Now D2 is the total dose which we need to calculate. One, D2 is now 4 gray. So dose per fraction is 4. Alpha beta ratio for late effect is 3. This will be equal to D1, that is 60 gray, multiplied by 1 plus dose per fraction is 2 gray and alpha beta ratio 3. And when you calculate, it comes out to be 43 gray. For early reacting tissue, everything remains the same except this alpha beta ratio. Now we will have to use alpha beta ratio 10, not 3. So when you put these value here and you calculate, this is a very simple mathematics. All of you can practice at home. When you calculate, it comes out to be 52 gray. Now, again, very serious message. Suppose you calculate the isoeffective dose based on tumor or based on early reacting tissue, then you will deliver 52 gray. While isoeffective dose for late reacting tissue is much less, 43 gray, but you will deliver 52 gray, which means you will causes more damage to late reacting tissue. And that is why I am telling repeatedly, I am trying to convince you that whenever you calculate isoeffective dose, always calculate based on alpha beta ratio of late reacting tissue. Never calculate based on alpha beta ratio of early reacting tissue or based on tumor. Now, this was the conventional fractionation. We have used many fractionation scheme like hyperfractionation, concomitant boost, continuous hyperfractionated, and of course the standard fractionation. So let me first look at the standard fractionation. So this is the fractionation which we use in head and neck cancer, 35 fractions, 2 gray per fraction, 7 weeks overall treatment time. Now from this slide onward, now I will calculate the biological effective dose for tumor, which is equally applicable to early effect, but I will call tumor because that is our area of interest or tissue of interest. And biological effective dose of late effects, and I will call it normal tissue, right? So these are the two areas of interest for any radiation oncologist, the tumor control and minimize the side effect, especially the late side effect, okay? So if you calculate the biological effective dose of conventional fractionation, the total dose is 70 gray. 1 plus dose per fraction is 2 gray and alpha beta ratio of tumor is 10. So it comes out to be 84 gray. For late effect, everything remains the same except alpha beta ratio, which is now 3 gray. So it is 106.7 gray. So this is the biological effective dose for conventional fractionation for tumor and normal tissue. And we can say that fixed schedule will have more BED for late reacting tissue than for tumor. Now let us go to hyperfractionated radiotherapy. Now in hyperfractionation, instead of single fraction per day, we are delivering 2 fractions per day with 6 hours interval between the 2 fractions. So total fraction will become 70 now instead of 35. Rest of the thing remains same, overall treatment time same, 5 days per week. But of course, the dose per fraction is reduced from 2 gray to 1.15 gray. So if you calculate the total dose now, it is 80.5 gray. So we can calculate the BED for tumor and late effect. Now this is very simple. All of you can calculate at home. So only you have to put these values. So total dose is 80.5. One dose per fraction is 1.15 divided by 10. So it comes out to be 89.8 gray. If you remember what was the biological effective dose with conventional fractionation, it was 84 gray, which means that this hyperfractionation radiotherapy will be more damaging to the tumor. So that is what I am predicting from linear quadratic model. Now late effect, again putting these value, alpha beta now 3, it comes out to be 111.4. And if you remember with conventional radiotherapy, it was 116.7, which means that hyperfractionated radiotherapy will be less damaging to late reaction or to normal tissue. So this is what I am predicting from linear quadratic model. And I predict that this higher BED with hyperfractionated radiotherapy should translate into increased tumor control and lower BED for normal tissue into reduced late toxicity. This is what I am predicting from linear quadratic model. And now I have to validate this prediction in my clinical setting. Because unless I find the prediction true in my clinical setting, I am not interested, as a clinician, I am not interested in any mathematical formula. Many mathematical formula will have no meaning for me unless this mathematical formula help me in predicting accurately in my clinical setting. Because I am a clinician, I am a person of medicine. So this prediction, whether is ultimately translated in our clinical setting or not, we need to do some trial. But before that, let me tell you that with hyperfractionation BED, we are delivering around 7% higher BED to the experimental arm than the control arm. Similarly, late responding tissue, we are delivering 5% less in hyperfractionated arm. Now, these changes in dose should be translated into a 12% increase in tumor control and around 20% reduction into late effect, that is subcutaneous fibrosis. This is what I predicted, from linear quadratic model. And from where I got these figure 12% and 20% from the biological model. Now, biological models nowadays are available with many treatment planning system, and this tissue control probability and normal tissue control complication probability is an integral part of that biological planning system. So from this biological model, I am predicting these two figures. And now let me see whether these figures are translated into my clinical setting or not. And this was validated by EORTC 22791 trial in head and neck cancer, conventional fractionation versus hyperfractionation, and look at the outcome. That local tumor control was 19% higher in patient treated with hyperfractionated radiotherapy. And how much we calculated? 12%. So I can say reasonably in agreement with the calculated one from the linear quadratic model. And now once it is validated in our clinical setting, as a clinician, I will start developing trust or faith in linear quadratic model. Regarding the subcutaneous fibrosis, there was no difference, while we predicted that there should be less subcutaneous fibrosis. So it means there may be two possibilities. Why it was not correct? There may be two possibilities. One, that probably linear quadratic model is not accurate, or second, probably there is problem in our understanding, and in fact, the later part is correct, there was problem in our understanding because it has been established later on that 6 hours gap between two fractions is not sufficient for complete repair of the sublethal damage, especially in late reacting tissue. It is sufficient in early reacting tissue, but not in late reacting tissue. And that was the reason that we did not get any difference between two arms as far as subcutaneous fibrosis is concerned. Another validation by RTOZ 9003 trial. These are the 4 arms: standard fractionation, hyperfractionation, split course, and concomitant boost. Now, I will just focus on these 2, standard and hyperfractionation. Look at the outcome. There was 8.4% improvement in local control, and how much we calculated? 12%. So I can say reasonably good in agreement with the calculated one from linear quadratic model. And again, my trust in linear quadratic model increases. This is the trial from Princess Margaret Hospital. This is an hyperfractionated versus conventional fractionation, though they have used a different fractionation scheme in both the arm, but since they use 2 fractions per day, so we call it hyperfractionation versus conventional fractionation. And again, if you look at the difference in the BED, it is around 2.41 gray, which means around 4% higher BED in hyperfractionated arm. And when you calculate, it comes out to be 6%. So it should translate into a 6% improvement in tumor control. Again, from the biological model, we get this figure. Let us look at the outcome. There was 8% improvement in hyperfractionated arm. So we can say closely, very, very close in agreement with the calculated one from the linear quadratic model. So again, my trust in linear quadratic model further increases. Now, for vocal cord, this is the recent trial, RTOG trial, conventional fractionation versus hyperfractionation. Again, if you see the difference in BED, there was 7% higher BED in hyperfractionated arm. We should translate into a 12% improvement in tumor control, and look at the outcome. 8% improvement. So again, I can say reasonably okay in agreement with the calculated one from the linear quadratic model. Then March meta-analysis. Now look at the outcome. There is around 10% improvement in local tumor control in hyperfractionated arm. Again, closely in agreement with calculated 12% from linear quadratic model. So all these trials ultimately improve or increase my trust in linear quadratic model. So that was about the hyperfractionated. Let me go to the chart. Now in chart, we are using 36 fractions of 1.5 gray per fraction, 3 fractions a day, 6 hours apart for 12 consecutive days. No holiday, no Sunday, no Saturday, consecutively for 12 days, which means total dose will be something like this, 54 gray in 36 fraction in 12 days. Again, you calculate the biological effective dose for tumor, it comes out to be 62.1 gray. With conventional fractionation, it was 84 gray, which means that if treated with chart, it will be less effective for tumor. Late effect, 81 gray. With conventional fractionation, 116, which means that less damaging to the normal tissue, which means that if we treat with chart, there will be compromise in local tumor control, but late side effect will be minimized. So this is what I am predicting from linear quadratic model. Again, I need to validate. It was validated by MRC UK trial, conventional fractionation versus chart trial. And let us look at the outcome. Let me first look at the late morbidity. But we expected late morbidity to be less. And what we got? Ultimately same thing on all parameter of late effect, that is telangiectasia, laryngeal edema, dysplasia, all parameter late morbidity was less in chart arm as compared to the conventional arm. Let us look at the tumor control. Now, what was our expectation based on linear quadratic model? It was that lower tumor control should be compromised, but we did not find any difference in local regional control. Again, two possibilities. One, either LQ model is not accurate in case of chart, or there is problem in our understanding. Again, later part is correct because we know that chart radiotherapy is completed in 12 days, while conventional radiotherapy is completed in 6 weeks or 6.5 weeks or 7 weeks. And we know that in head and neck cancer, there is an accelerated repopulation during radiation. So you cannot compare directly chart, which is completed in 12 days time, with a schedule which completes in 6 weeks time. You cannot compare unless you incorporate a time factor in linear quadratic model. So we need to incorporate a time factor in linear quadratic model, and this time factor will depend upon many factors like timing of repopulation during radiation treatment, potential tumor doubling time, and total duration of repopulation. And without going into detail of mathematics, this is the expression for time factor. 0.693 T upon T pot, where T is the total duration of the accelerated repopulation in days, and T pot is potential tumor doubling time. Now, this accelerated repopulation is a good thing or a bad thing for tumor control? All of you will say it is a bad thing because during treatment, new cells are being added. So some dose of radiation will be utilized to counter the effect of this accelerated repopulation. So naturally, your effective BED will be less than what you calculate. So naturally, this expression has to be minus from biological effective dose formula. So this is the BED. From this, we have to minus this expression. So finally, the effective biological effective dose will be total dose multiplied by relative effectiveness minus accelerated repopulation. Now, so this is the expression, final expression for accelerated repopulation. Now, T is the total duration of accelerated repopulation. Now, this can be replaced as capital T minus Tk. Capital T is overall treatment time. Tk is basically time when repopulation starts. So it means same, that total duration of accelerated repopulation. We know in head and neck cancer, repopulation usually start after 21 to 28 days. The alpha is basically in head and neck cancer is taken as an average of 0.3 per gray. T potential is taken as 2 to 25 days in head and neck cancer, and we take a median of 5 days. So we can calculate the dose of radiation which goes waste due to accelerated repopulation in a regime which finishes in 6 weeks time or 39 days. So we can put the value here in this formula. So 0.693, alpha is 0.3, total duration of the treatment is 39 days. Accelerated repopulation start at 21 days, divided by potential tumor doubling time is 5. And when you calculate, it comes out to be 8.3 gray. For a 7 weeks treatment, which completed in 46 days, again, you can calculate putting these value here. Now, total treatment time will be 46 days. So when you calculate, it comes out to be 11.6 gray. And when you calculate the dose of radiation because of accelerated population per day is 0.46 gray per day. And remember, this is the dose of radiation which goes waste, because if there is no accelerated repopulation, all the dose which you deliver on a single day will be utilized to kill the existing cancer cell. But new cells are being added because of this accelerated repopulation. So 0.46 gray out of 2 gray which you deliver per day is utilized to counter the new cells which are being produced as a result of this accelerated repopulation. So two messages are very clear, that this dose you have to reduce to get an effective BED, and as the overall treatment time increases, the dose which goes waste keeps increasing and your effective BED keeps decreasing. So now putting this value in a table form, conventional radiotherapy, 6 weeks time, this is before time factor is incorporated, but we know that this dose will go waste in 6 weeks. So effective BED will be this. For chart, this is the BED calculated, and since it is finished in 12 days and accelerated repopulation starts after 21 days, so there is no dose of radiation which goes waste. So it remains same. For hyperfractionation, 7 weeks, this is the BED, but in 7 weeks time, this dose goes waste. So effective BED is this. For conventional fractionation, 87 weeks time, 84, but this goes waste. So this is the effective BED. Now, if you see in this table, the conventional fractionation and chart both have almost similar BED, and that was the reason that in chart trial, we did not get any difference in local tumor control. And with this knowledge, the authors concluded that chart is not better than conventional radiotherapy based on T potential of 5 days, but probably chart may be effective in a very fast growing tumor with potential tumor doubling time of less than 3 days. This is what they hypothesized based on these data. And to confirm these data, they retrospectively analyzed their clinical data and published separately, and they found that EGFR receptor expression is a predictive factor for a benefit from chart. So what they did in this analysis, they divided their population based on EGFR into two, when EGFR is less than median, when EGFR is more than median. And when they analyzed the data, they observed that in patient having EGFR less than median, there is no difference between the two arms. But when patients having EGFR, excuse me, when EGFR is more than median, there is a statistical significant difference between the two arms, and they explained it that overexpression of EGFR leads to higher proliferation and less potential tumor doubling time, maybe less than 3 days. That is the reason that in a very, very fast growing tumor, when you reduce the oral treatment time, then chart will be better. And this opens a new area of research for radiation oncologists, and that is the personalized fractionation scheme based on molecular marker. Ladies and gentlemen, we all know that medical oncologists now practicing personalized medicine based on molecular tumor marker. They are using targeted therapy. In the same direction, we have just started moving based on these retrospective data. There are other data also which I will discuss just now. But in future, we have also started moving in the same direction where we can utilize personalized fractionation scheme based on molecular marker. There are other data which suggest that when you have patients with EGFR more than median, then there is very high failure rate as compared to patient having EGFR less than median. Similarly, these patients have low or inferior overall survival. The same data from a surgical series that if you have high EGFR, you have worse prognosis as compared to patient having low EGFR. Now coming on to concomitant boost. Now what is concomitant boost? Just to explain, in concomitant boost, you treat first whole neck along with the primary tumor and deliver a dose of 1 Gray per fraction, 30 fraction in 6 weeks, 5 days per week, and total dose is 54 Gray. In last 2.5 weeks, you add another small portals covering the primary tumor and deliver 12 fractions of 1.5 Gray, 2.5 weeks, total dose 18 Gray. So in last 2.5 weeks, you are delivering 2 fractions per day with 6 hours interval in between. So the total dose is 72 Gray in 6 weeks time. And again, you can calculate the biological effective dose for tumor. It is without time factor, it is 84.4, but it is a 6 weeks treatment. So naturally 8.3 Gray will go waste. So effective BED will be 76.1. And if you remember, with conventional fractionation, we have 72.4 gray, which means if we treat with concomitant boost, it will be more damaging to the tumor. Similarly, for late effect, this is the biological effective dose with conventional fractionation. Biological effective dose is higher, which means it will be less damaging to the tumor. So again, we need to validate what we predicted, that it should be concomitant boost should be high damaging to the tumor, and it should result or it should translate in our clinical setting into higher tumor control. So again, validated by 9003 trial, and now we will just focus on standard fractionation versus concomitant boost. And expectation is that 5% increase in BED should translate into a 9% improvement in local tumor control. So that is what I predicted from linear quadratic model. And let me look at the outcome. 8.5% improvement, very, very close in agreement with the calculated one of 9%. So this again is very interesting that what we calculate from linear quadratic model is ultimately translating into our clinical setting. Now putting these value here, and now again, if you look at these last two, they almost have similar BD, which means they should have similar local tumor control. If you look again, the same data RTOZ 9003, now you just look at the hyperfractionation and the concomitant boost, you will see almost similar outcome in terms of local tumor control, the same thing which we predicted from linear quadratic model. So we have discussed all kind of fractionation scheme, and with linear quadratic model, we are very much satisfied as a clinician because we have seen that what we predicted from the linear quadratic model ultimately is being translated into our clinical setting. Now this dose of radiation which goes waste because of accelerated repopulation, which is known as deproliferative, we calculated from linear quadratic model. Now the same has also been calculated or estimated from clinical data. Now, this is the clinical data from which the deproliferative has been calculated. Now, this clinical data shows relationship between TCD50 versus overall treatment time in days. What is TCD50? It is basically the dose of radiation which result into 50% control of the tumor. So what it suggests, if the overall treatment time is finished in 21 or 23 days, there is no change in dose. But beyond this, as you increase the overall treatment time, total dose to get a 50% tumor control keeps increasing. And from these data, deproliferative was calculated to be 0.6 gray per day. And how much we calculated from linear quadratic model, if you remember, 0.46, so very close. So again, we can say that what we predicted from linear quadratic model is also validated in our clinical setting. In fact, for head and neck cancer, for various subsites, from clinical data, we have calculated the deproliferative. It varies slightly from one subsite to other subsite, and we take a mean of 0.64 gray per day. Now, so this is from clinical data. Now, by now we have probably understood the importance of overall treatment time. If we increase the overall treatment time, the impact of accelerated depopulation will be higher in negative form, and it will compromise our tumor control. At the same time, if we reduce the overall treatment time, then the effect of accelerated depopulation will be less, and we predict a better tumor control if we reduce the overall treatment time. So this is what we predict from linear quadratic model. So let us look whether it is translated in our clinical setting or not. So this statement that if we reduce the overall treatment time, we should have improved local tumor control is validated by famous Dhenka 6 and 7 trial. A very simple maneuvering in this trial. The 5 fractions per week is compared with 6 fractions per week. The rest of the things are same in both the arms. 66 gray, 66 gray, 33 fraction, 33 fraction. 45 days, 38 days, because they are treating 6 fractions per week. So just by adding 1 more fractions per week, they reduce the overall treatment time by 7 days. And we know that dose compensated for repopulation per day is 0.6 gray per day. So when you reduce by 7 days, naturally you gain the biological effective dose. And it will be then 0.6 multiplied by 7, that is 4.2 gray you gain, which is roughly 6.5%. So this 6.5% gain should translate into an improvement of local tumor control to the tune of 12%. So this is what we are predicting from linear quadratic model. And let us look at the outcome. There is a 10% improvement in local tumor control. So we can say closely in agreement with the calculated one from linear quadratic model. Very interesting. But these authors, when they did a subset analysis, they found that when you reduce the overall treatment time by 7 days, all the patients are not benefited. Only patient having well-differentiated and moderately differentiated tumors are benefited. Poorly differentiated tumors are not benefited. So again, we are moving towards personalized fractionation scheme based on grading of the tumor. Now the question is why? The explanation which authors gave is very interesting. Just try to understand. We know that cancer is basically arise from normal mucosal epithelium. And this, this normal mucosal epithelium we know has a tendency to undergo accelerated repopulation in response to some injury, which I have already discussed, that they remain in steady state, but as a result of injury, they go into regenerative state. So as a result of injury, they go into regenerative state. Now this cancer cell, to retain the same function, that is, in response to injury, they should undergo accelerated repopulation. So to retain the same function of its parent cell, then they should have some morphological similarity with the parent cell. And out of these three, you tell me which type of tumor in terms of grading have the most morphological similarity with parent cell. It is the well-differentiated tumor. And to some extent, moderately differentiated tumor, poorly differentiated tumor have no similarity. So that is the reason that we get better result in well and moderately differentiated tumor, but not in poorly differentiated tumor. Indirectly, the authors suggest that accelerated repopulation is only observed in well differentiated tumor and to some extent moderately differentiated tumor. Now, same observation they made in more recent publication in DANCA 6 trial, that when you reduce the overall treatment time by 7 days, then it only benefits the well and moderately differentiated tumor, but not poorly differentiated tumor. The another trial which suggests the same thing, that when you reduce the overall treatment time, it helps in improving the local control. This is an multicentric IAEA study, 6 fraction versus 5 fraction. It was a multicentric trial. 2 centers from India also participated in this trial, TMH and AIMS, and look at the outcome, 12% improvement. And how much we calculated? Exactly 12% came from linear quadratic model. So very interesting. And I mean, this generate our interest in linear quadratic model, that whatever we predict in linear quadratic model ultimately translate into our clinical setting. March meta-analysis, 8% improvement. Again, we can say, closely in agreement with calculated one from linear quadratic model. Now, these authors also try to find out any other predictive marker for reducing the, for benefit of accelerated radiotherapy, and they found T53 mutation. So they retrospectively analyzed their data and published in a separate article. What they did, they divided their population of patient into 2 categories, one with TP53 wild tumor, another with TP53 mutated. And when they analyzed their data, they found that modest acceleration by reducing 7 days does not benefit patient with wild 53 gene, but certainly will benefit, which is statistically significant in patient which is T53 mutated. So all these data again, taking us towards the same, path, that is personalized fractionation based on molecular marker, based on grading of the tumor. So we are moving in this direction, but remember, ladies and gentlemen, that all these data are retrospectively, and they so far have not been explored prospectively in a randomized setting. So all of young radiation oncologists, budding radiation oncologists, have ample opportunity to take, any of the research, to prove or disprove these retrospective, data. So there is a very good opportunity for all of you to take these research in future in a prospective randomized trial. Now, question is that why, why it was not seen in wild type tumor, only seen in mutated type tumor. So again, the explanation is very interesting, which authors gave. Now we know that there are checkpoint in cell cycle. Now this checkpoint, which is at the end of G1, is governed by P53 gene. So what happens when there is a radiation damage? This gene get activated and it increases the production of P53 protein. And then this, because of the activation of this gene, there is cell cycle arrest here. So there is a cell cycle arrest, which means that it results into increase in cell cycle time. So there is a cell cycle time increase, which means that repopulation is now less. So when you reduce overall treatment time by a modest 7 days, probably it will not benefit. While in patients who have mutated P53 gene, then what happens that when there is a DNA damage, now this gene is no more functional, so there is no production of P53 protein. There will not be any cell cycle arrest. It will just move on to the next phase of the cell cycle. So there will not be any cell cycle delay, and there will be increased repopulation. So when you decrease the overall treatment time by modest 7 days, then it will help, these patients who have mutated P53 tumor. Now the same authors, similar to chart, looked at the epidermal growth factor receptor and also, the tumor differentiation, which they published in a separate article. Now again, they hypothesized that overexpression of EGFR will lead to higher proliferation. So naturally, when you reduce the overall treatment time, you will counter the accelerated repopulation. So again, you see when patient having low EGFR, there was no difference. But when patient having high EGFR, then only you could get a difference in local tumor control. So similarly, for the grading of the tumor, there was no difference in poor differentiated, but there was difference in well and moderately differentiated, and explanation I have already discussed. So ladies and gentlemen, the accelerated radiotherapy will not benefit across the board. It will benefit as based on retrospective data. It will benefit only patient with P53 mutated cancer, EGFR overexpressed cancer, well and moderately differentiated cancer. But remember, all these, conclusions are based on retrospective data. We still need to confirm all these conclusions on prospective randomized trial, and these research areas are open for any one of you to take this research further. So I think Dr. Deepa, it is 7:30, more than 7:30, so I can stop at this point of time, and we'll continue from here tomorrow. But I can take questions, some questions which are important in your view, which are more important. I can take some questions.
Okay, sir. Sir, there is one question in hyperfractionated schedule. what will happen to the acute toxicities? Will it increase?
Yes, certainly it will increase. Yes, certainly it will increase, but it is manageable because most of the, data, clinical data suggested the same thing, that there will be increase, but it is manageable. And rightly so, as you have seen that, if there is increased tumor control, means there is increased damage to the tumor. And early reacting tissue have the same alpha beta ratio as tumor. So naturally for early reacting tissue, the biological effective dose with hyperfractionation are higher. So naturally the toxicity will be higher, but it is manageable.
So another thing is, what is the significance of increasing beta cell kill?
Okay, so basically if you increase the beta cell kill, the overall tumor control increases. You are potentiating the effect of radiation. So that is basically sensitizing the effect of radiation.
Sir, another question is, like, in poorly differentiated carcinomas are more radiosensitive, but why in the Dahanga series it showed a different effect?
Why in?
The Dahanga series, it showed a different.
Because this is what the explanation was given by the authors, that they are most sensitive, and when okay. So he's asking, the person is asking that there is no accelerated repopulation, it is more sensitive, but why why there is a less tumor control, or why there is no benefit of accelerated radiotherapy. See, I think they have not. The aim was not to see the effect of radiation on various types of tumor, grading of the tumor. The purpose of the study was to see the effect of accelerated radiotherapy, right? It was to see the effect of accelerated radiotherapy on tumor control. And when they divided as per grade, they observed that effect was seen only in well and moderately differentiated tumor, not in poorly differentiated tumor, right? They have never said that poorly differentiated tumor, if you suppose treat with radiation, what will be the effect of radiation based on grading of the tumor, right? For example, suppose if you give whether conventional fractionation 70 gray, then unless you see the effect based on grading, only then you can say that poorly differentiated tumor have less tumor control, or well differentiated tumor have less tumor control. So that was never the aim of the study. The aim of the study was to see the effect of reducing the overall treatment time by 7 days on different graded tumor. So that was the aim.
So there is another, in fact, a long question. I'll shorten it. It's in a head and neck cancer. A patient was planned with the conventional radiation, 70 gray in 2 gray per fraction. But after 5 weeks, the patient is having mucositis and treatment break of 1 week. And if the remaining 20 gray is given in next 2 weeks, what is the predicted loss in tumor control probability?
So basically the gap correction, we need to do a gap correction, right? So we have to do a gap correction and deliver the missing dose. So once you do a gap correction and overall treatment time remains the same, so there will not be any difference between the tumor outcome.
There is one question. What is the benefit of 55 gray in 20 fraction versus 60 gray in 30 fractions in lung cancer?
Okay, so basically, you calculate your BED. You calculate your BED, right? And you can find out, which one is better. Whether if BED is higher, one schedule is higher than other. Naturally, we expect more tumor control. But at the same time, you must remember that when you are increasing the dose per fraction, so you have to be very careful about the surrounding normal tissue. You are not causing more damages to the surrounding normal tissue. And for this, you have to use the modern radiotherapy technique like Imrt, IGRT, or the motion management, everything.
And so there are a lot of thanks and appreciation. So I'm finding it difficult to get the questions.
Okay.
Question is like, can you explain, is there a radiobiological basis for why in early laryngeal cancers, hypofractionation is better?
I was expecting this question, and the answer is already in my next module. So I will not disclose answer today. Next module, tomorrow, you will get the answer. Already incorporated in my module.
And there was one basic question in when we were talking about azoospermia, will already formed sperms also be killed by radiation?
Usually not. Usually not. But of course, if you deliver very high dose of radiation, maybe, but usually not, because these are the functional cells, And if you remember my first module, or maybe in second module, I said that unless a cell attempts to divide, radiation usually will not kill, except two exception I gave, the oocytes and lymphocytes. But certainly there may be, there may be mutations, or there may be so many things.
Another question is there, like exactly how many days is gap correction beneficial? If there is a gap of 2 months, can we compensate it?
Very difficult, not possible. Very difficult.
So there are questions on re-irradiation. I hope it will be covered in the next module.
Re-irradiation I have already covered.
Okay. Carotid re-irradiation dose, there is a question.
So basically, the carotid re-irradiation dose, or we do not know exactly what dose should be ideally given to the carotid. We do not know. We don't have any answer. It's only, clinical series which suggests that, whatever the data are there, it's whatever doses they have used during re-irradiation, especially of head and neck region. For example, usually RTOG trial has gone up to 60 gray after during re-irradiation, and the side effects of carotid artery was seen in less than 5% of the cases. So exact, we do not know.
Sir, there is one question on tumor doubling time and its clinical implications.
So tumor doubling time is basically related with accelerated repopulation. If the tumor doubling time is less, naturally tumor is very fast multiplying and adding new cancer cells. So if you give the treatment in prolonged time, naturally it will not be very effective. But if you reduce the overall treatment time, probably it will be better. So that is the the implication of tumor doubling time. I mean, if the tumor is very fast growing, it is better you finish your treatment much earlier, or you plan treatment, or you plan an accelerated treatment or concomitant boost. Probably that will be better.
There is one question, sir, like does the Hunger 6 and 7 defy role of Bergoni and Tribondi?
Pardon? Can you repeat?
Does the Hunger 6 and 7 trial defy the rule of Bergoni and Tribondi?
No, I didn't get the question. In Danka 6 and 7 trial define?
Does it defy the rule of Bergoni and Tribondi? Like maybe we can take it next time. Like I'll
ask this person to elaborate further, and I can answer tomorrow. So if he can.
Yeah, it was given some time back. So if the person who is
if still the person is on, then he can write down, elaborate more than only because law of Bergoni and Tribondi will be utilized in explaining one of the fractionation scheme tomorrow. But as far as the Danka trial is concerned, I am not getting exactly what the person wants to ask.
Sir, what is the effect of hyperfractionated accelerated schedule in acute and late toxicities? Probably charge. I mean, it's hyperfractionated accelerated schedule in acute and late toxicities.
See, I think I have given you the basics. You calculate the BD, just calculate the BD and you will get the answer. You calculate BD for early reacting tissue. If it is more than conventional fractionation, you will get higher toxicity. Similarly, for late reacting tissue, if it is more than conventional, it will result into higher toxicity. So if you understand the basics, just any schedule for all participants, any schedule, just calculate the BD. If in reference to whether you are calculating in reference to tumor or in reference to late reacting tissue.
So there is one question. If patient who is on conventional radiotherapy develops severe mucositis and requires treatment gap, so like what is the maximum gap we can give? Like if there is a gap of more than 1 week, till how much gap we can give a gap correction?
See, again, there is no cut off that till what gap you can give a gap correction, right? So the basic principle of gap correction is that try to finish the treatment in planned time. Whatever you have planned initially, try to finish that treatment, which means that after gap, you will have to deliver either one fraction extra for the rest of the time, for rest of the weeks. So give 6 fractions, or maybe give 2 fractions as a hyperfractionation. I mean, 1 fraction on the 5th day, but after 6 hours of interval, or treat on Saturday also. So you try to finish the planned treatment in overall treatment time. Don't go beyond the overall treatment time, because the moment we go beyond the overall treatment time, naturally, somehow we will compromise our outcome. But many times it is not possible, I tell you, many times it is not possible.
Sir, other questions are very similar only, and I think it has been covered in the...
Okay. So once again, thank you very much. I think we will meet tomorrow again at 5:30 sharp. So I will request all of you to be here by 5:30, because there are a lot of more interesting things will be coming, in next modules. Next, you will see the radiobiology of hypofractionated radiotherapy, especially the extreme hypofractionation, like SRS and SBRT, which we are using nowadays for many cancers and many benign diseases. So all of this will be covered. So thank you very much, and have a good night. Thank you very much. So I'm stopping sharing and I'm leaving.